Everyone, I think we are going to get started. Okay, you can move it back.
Oh, you can move it back. Yeah. Okay. Do you want me to be like, hey?
Hi, everyone. We're going to get. Do I need to implement some consequences? Ooh, thank you. Topical joke. So this is great to see a really good turnout for this talk, and I can see a lot of different disciplines represented and a lot of different areas of Holland Bloorview, which is also excellent because I think the topic of behavior cuts across pretty much everything that we do here. And if you don't believe me about that, Justine will probably convince you by the end. So the idea for this talk grew out of our Behaviour 101 seminars that we have been running through the No Boundaries Fund. And those are seminars that we've been offering to families to learn more about their child's behavior. But we were having staff start to ask if they could attend the seminars. So we thought, well, why don't we do a knowledge connections to give staff the opportunity to learn some of this material as well. So I would like to introduce our esteemed speaker, Justine Wiegelmann. Justine is a senior therapist at the Geneva Centre for Autism, a board-certified behavior analyst, and holds a master's degree in developmental psychology. In her work at the Geneva Centre, she works with families to address severe maladaptive behavior and skill deficits in children and adolescents with autism, conducts parent education and training, and consults the psychopharmacology clinic here at Holland Bloorview, which is how I got to know Justine. Justine is passionate about collaborating with interdisciplinary teams to support children with various disabilities to more fully participate in therapeutic and recreational programs, which fits very well with No Boundaries. So with that, I will turn it over to Justine.
Okay, great. I'm so glad that there's such a big turnout. I'm really excited to come and to be able to share this information with you because we're giving it to a lot of parents. And it's so nice to hear that other staff, US staff, are showing so much interest in it. So as Melanie said, this workshop we're running here at Bloorview has been really successful, but I will tell you it's a 4-hour workshop, and I'm going to condense it into an hour. So I really want this to be as beneficial to you as possible. So I'll try to get through the material, but then I want to leave some time at the end because I really want to be able to answer your questions. Because dealing with problem behavior is a really broad, big topic. And really, anytime we're dealing with a behavior, we're looking at individualized supports and strategies that fit that child or that family's need. So I'm going to give you some really broad understanding of behavior today, hopefully, and some broad strategies to use, but then at the end we'll have time where I can clarify anything, or if you have a patient that you're thinking of or a challenge that you faced before that you just want some insight into, I'm happy to answer. And then I'll also give you my email as well, because if for anybody who knows me, I can talk for hours about this, and I'm happy to do so if you want me to. Just so I can get a good understanding of everybody in the room, who feels like they have an understanding of applied behavior analysis? Okay, great. So about half. Okay, so I'll just go over it briefly. So this is the practice that a behavior analyst uses. It's kind of our science and how we understand why we do what we do and how we learn. So you hear the word ABA often used for autism treatment. It's really helpful in autism treatment, but it's just helpful in terms of any learning or dealing with behavior. Okay, so when we're talking about applied behavior analysis, we're really looking at behaviors that are meaningful for their child and their life. So they're applied. They actually make a difference to the child's quality of life. When I say the word behavior, I just mean anything that's observable or measurable. So right now I'm talking to you all, I'm engaged in a behavior. You can see and hear me talking to you. And then it's analytic in nature. So we use data to determine why a behavior is happening. And then once we have a good sense of why it's happening and we have an intervention in place, a key component of applied behavior analysis is collecting ongoing data so we can evaluate whether or not the intervention is successful. And if it's not, we make changes. And if it is, we keep doing what we're doing. So we can use those principles for applying to any learning that we're doing, but when we're talking about it specifically for challenging behavior, there's kind of a stepwise procedure. So I'll outline it here and then we'll go through each of them. So the first thing that we're looking at is actually defining what the behavior is. And then we're trying to do some assessment to determine why the behavior is happening. And then we can look into treatments that's including preventing the behavior, teaching the child the more appropriate behavior to engage in, as well as adjusting the consequences or how we respond to behavior to hopefully make it less likely to happen again. And then there's the continual evaluation of the changes of behavior that I just mentioned. Okay. So the first spot is, the first step is to define the target behavior. So when we're talking about behaviors, it's most helpful if you actually just talk about what you're observing. So be really objective about the behavior. What are the things that you're seeing and hearing? This helps avoid confusion because people have different definitions of what a tantrum or a meltdown means for different children. We all have different meltdowns if we think about our own. It also is a way to talk about behavior that's not using any judgment. We're just talking about what's happening and we're not inferring about somebody's mental state because we might be wrong unless they're directly telling us how they feel. And it also helps us really look to evaluate progress because we know what we're targeting. Now, I know that at Bloorview you have some inpatients where you can look through and define behavior, but you also have patients that just come in and it's the first time you're meeting them. So if you ever have pre-clinic phone calls or appointments or the parents are talking about behavior, I just encourage parents to tell me about what do you see and hear. If I was looking through your window at home and your child was having a meltdown, what would I see? And that usually helps parents be a little bit more focused about what the challenge is. Okay. So once we know what the behavior is, the biggest component of the assessment, the whole assessment is focused around why is the behavior happening, right? All behavior happens for a reason. Even when we see kids who engage in maladaptive behavior that might be dangerous or harmful to them, it's serving a purpose for them. It's not happening out of the blue for no reason. And so really we have to figure out what is the function of the behavior, okay? And the easiest way to remember it, and a good way to talk about it with parents too, is what is the child getting or getting out of or engaging in the behavior? If you can answer that question, you know what the function is. You know what purpose it serves. And of course, it might be serving multiple purposes. Behaviors are never that simple. But if you can answer that question, you have a good hold on your understanding of it. So when we are thinking about what kids get or get out of behavior, we can categorize it into one of 4 different functions of behavior. Okay? So sometimes you might, if you get any reports where there's been a behavior analyst or if somebody's asking you in a clinical setting or somebody you're collaborating with says, what's the function? They're looking for one of these 4 things. Okay? And behavior analysts classify all behavior into one or more of these 4 things. Okay? So the first one is to escape or avoid a situation. So that's just leaving an environment that you don't like or trying not to get into the environment in the first time, right? So if we think about a kiddo who comes in and flops when they get outside of the elevator on the floor where you're gonna have their clinic, we could think about maybe flopping is to avoid going into the clinic room. We also have behaviors that are maintained by attention. So in this way, we see that a child is engaging in a behavior to try to get attention of somebody else. Sometimes this attention can be positive, but it's really important to remember that some kids really thrive on negative attention too, or what we would call negative attention, so reprimands or yelling. I've worked with a lot of kids that really love being yelled at. So in the same, right, I don't like it, but so in the same way that we might have a kid flop for a skate, we could have a kid flop to the floor as a way to try to get attention of other people, right, or some sort of comfort or soothing too. We also have behaviors that are maintained by access to tangibles. So this is where they're trying to actually get some physical thing or access to an activity. So the kid who flops, it might be that they're waiting for their parents to offer them the iPad or give them a choice of other things that they can have. Okay? And then the last function of behavior is called automatic reinforcement. I put sensory up there. Do we have any OTs in the room? Yeah. Oh, yeah, my was right there. So I put sensory up there because most parents hear sensory, and the term automatic reinforcement is super technical behavior analytic language. So probably what an OT and a behavior analyst thinks are sensory are similar, but kind of a bit different. The way that a behavior analyst conceptualizes a sensory behavior is just that the behavior in and of itself is reinforcing. So it doesn't matter what anybody else does. So things like twirling hair, flapping, chewing gum, either it's calming, it's soothing, there's some sort of sensory component to it, but it's self-reinforcing. Okay. So how do we figure it out? How do we figure out, if we can't answer the question, what are they getting or getting out of it? So we want to look at the behavior within its environment. Okay? So the first thing that we want to look at is what's happening before the behavior. These are called antecedents. And you can think of antecedents as just a fast trigger. Right before the behavior, what was happening? We can also think about antecedents as slow triggers. So these are things that build up throughout the day. So it's things like if they have a doctor's appointment that they don't normally have, if they've started a new medication, if they're tired, if they're ill. So it's not something that happens every day to them, but something out of the blue that kind of makes it more likely that they'll have difficulty tolerating things that they don't like. You can probably think of yourself, mornings where maybe the power went out, your alarm clock didn't go off, you're late for work, all of those things. Those are setting events for us that may make it more difficult for us to function in our day too. Can everybody think of a morning like that? Yeah, you had one this morning. Watch out for her behavior. So these kind of are the conditions in which behaviors occur. They don't necessarily cause behavior, but they set the occasion. They make it more likely that behavior will happen. Then we actually have the behavior. And then the most important thing to look at is the consequence. So a consequence is just whatever follows behavior. So whether it's positive, it feels nice to give or not, it doesn't matter. It's just whatever happened after the behavior. And then the consequence will either strengthen the likelihood that that behavior is going to happen, which is called reinforcement, or it will reduce the likelihood that the behavior is going to happen again, which we call punishment. Okay? So it's just if a behavior is strengthened, it's called reinforcement. So as an example, we can see here where this kiddo, let's say they were engaged in some physiotherapy and it was time to practice going up the stairs, started pulling out the hair, and the therapist says, okay, we can try again later, which is a reasonable thing. If a kid is pulling out their hair, I would understand why somebody would do that. What happens is then she avoided the practice and then maybe more likely in the future to engage in the behavior again. So then it's strengthened. So if a behavior keeps happening, any behavior, if it's happened more than once, it's happening because it's been reinforced, or more simply, because it works. This is challenging for all of you as clinicians and people who clearly are trying to help kids and their therapies and get better, because it seems uncomfortable to hear that you may be reinforcing problem behavior, that parents might be. But it's important to remember that these things happen accidentally. And we respond to behavior the way we're going to respond, especially when behavior is dangerous or scary, like pulling out hair. But it's just important to know if we keep seeing it happen, then we have to look back and say, okay, how are we responding to it? We might accidentally be making it worse. And we might have a minor problem that ends up becoming a much bigger problem because we've accidentally been reinforcing it. Okay. And this is really hard for parents too, because you don't want to ever think that you're reinforcing challenging behaviors, but it's been happening. And so reinforcement occurs when you get something you want, or you get out or avoid something you don't want. Okay. So most behavior consultant is talking to a family or collaborating with other professionals and we're looking at challenging behaviors, the first thing we do is give the clinician or the parents what's called an ABC data collection sheet. So in the invite, I think they added some attachments, so you have it there, so that you can print this and give it to families or use it or modify it for yourself, whatever makes the most sense. And basically, it's just a log, so every time the behavior that you're looking at occurs, the caregiver would write on one row if there were any setting events, those slow triggers that they know of, sometimes there's not, what the antecedent was, the specific behavior, and then the consequence. And they record that every single time the behavior occurs over the course of a few days. Once you have that, you just look it over and look to see some general patterns. So in the antecedents and setting events, you can look at to see just generally when does the behavior happen. That might give you some insight into things that you can do to prevent it if you know what might be happening before. And then in the consequence section, you can really look at it to see that what are they getting or getting out of it, right? And that will lead you to the function. So if you see that every time they hit their brother, they get to keep the iPad for a little bit longer, well, then they're delaying the termination, right? So, okay, I want to spend more time actually talking about strategies and then have questions. So the next slides I kept in just in case anybody asked me for the slides and wants to learn more about how you would look at the ABC data sheet to determine the function, because on each subsequent slide it talks about every function. So I'll see if anybody has any questions about function before I move on, but otherwise I'm going to skip through these slides, and then if you'd like them, I'm more than happy to provide them. Does anybody have any questions about functions of behavior? Yes.
So how do you conceptualize like pain as a possible reason to be seeing behavior? Because it's always one of the things that we're taught to think about when we see self-injury.
Yeah, so you would, sorry? So the question is how we would conceptualize pain as behavior, because sometimes when we see self-injury or other things, we're wondering if maybe the child's in pain. So what we would look at is we would especially pay attention to the setting events to see if there were any changes in their sleep routines, anything like that. We would also look at the consequences and see how if we're responding. So sometimes if it doesn't follow the same, if you kind of see that the consequences are all over the place, there's not a general pattern, that's a pretty good indicator. But also, just as a rule of thumb, whenever we see anybody who's engaged in self-injury, or like if they're like hitting themselves in a certain way, or if something just starts happening out of the blue, we would always say, get it checked out medically first. Thank you. Yes, always. To rule those things out. Okay, so now that we kind of understand, looking at the behavior in the environment to kind of figure out the function, what the child is getting or getting out of the behavior, we want to think about, okay, what can we do about it, right? So we use this model called the competing behavior model, and it's just a way to conceptualize making a plan that involves 3 key components. Okay, as much as we can. Sometimes in different settings, especially hospital settings, you can't necessarily apply all 3 components, which we'll talk about. But in general, we want to look at preventing the behavior from happening in the first place. We want to remember that behaviors are happening for a reason, so we want to replace it. And then we also want to look at how we can modify the reinforcement they're receiving or the way we're responding so that we can reduce it. Okay, so really in prevention strategies, we're looking at making changes in the environment, and the goal here is to make the problem behaviors irrelevant. So if we can make changes in the environment and then the behavior doesn't need to happen, perfect. To a point, right? So we also don't want to change everything in the environment so the child can tolerate everything, because we do have I've worked with some families where the parents aren't allowed to talk to each other at dinner. So that's something where they kind of have done so many preventative measures that it just kind of gets out of control. So this is to a point, right? We shouldn't be afraid of behavior. That's where the learning happens. So we want to think about skill promotion. Behavior's happening for a reason. So what can we do instead? Can we teach them to do something instead of the problem behavior that serves the same function? So if they're trying to get out of a task, asking for a break or asking for a minute. Or we might have to be looking at teaching them the skill of tolerating aversive things, right? So if you're coming to the hospital, you might need to have treatment. Like you can't say no thank you. Maybe not. So sometimes the skill is actually just teaching tolerance or accepting no, and we want to teach these things in a way so it's easier to do the replacement skills instead of the problem behavior, and then that way the problem behavior is less efficient, right, and less likely to engage in it. And then the last thing we want to do, which is really the most important component, is looking at how we can modify the reinforcement. So remember, if behavior is happening, it's because it is being reinforced. So how can we change that? Can we eliminate the reinforcement? Can we reduce the reinforcement in any way? And if we can do that, can we make the behavior ineffective? If the behavior doesn't work anymore, it will stop. But I'll tell you in a minute that that's actually very hard to do, but we can do it. Okay, so also in the attachments that you have is a form called of the competing behavior model that we go through with families just so that they can kind of identify what's happening generally in the environment, what the function is, and then they can actually lay out a plan that addresses all those 3 components. Okay, so you can take a peek at that, and again, feel free to use it, change it, give it to people, it doesn't matter. Okay, so let's talk about now the prevention. Okay. So the prevention is often, it's often very important in settings like at Bloorview, especially when you have kids that are coming in occasionally, right? If you have a kid that's coming in occasionally and engages in maladaptive behavior when they're here, you might not be looking at creating a huge behavior plan to deal with every time they come if they're coming once a year or once every 6 months. But if you have an inpatient where they're here, every day and there's an ongoing behavior, then you are looking at creating a behavior plan. But in both cases, you can implement some preventative strategies. So I'm going to go through a whole bunch. There are so many preventative strategies, and some of them you might think of patients that you're like, yes, this would work. Some of them you think that wouldn't work in my clinic or what I do. That's okay. You can pick and choose which ones you think would be helpful. And if one wouldn't be helpful for a kid, don't use it. And the other thing is, these are kind of freebies. These things are not going to make behavior worse. So you can try as many of them as you want, and it's unlikely to make things worse. Okay? So really, when we're talking about prevention, just think about the triggers that you've identified and looking at, okay, what can I do to reduce them? So some common things that we look at are things like, do we need more routine, structure? Do we need things to be more predictable, right? Does the child know what's happening? Do they know what your expectation is? Right? We want to create predictability around them so they know exactly what you expect, what's happening to them when they're coming, especially if it's a new situation, if they're coming to Bloorview for the first time. If you are able to talk to parents beforehand, letting them know to talk to their child about it, or even if you're greeting them outside the clinic room, talking to them about what you're going to do, what's the plan going to be, so that it's not, this big scary place. We can use different types of supports in addition to talking to them. So we can use visual supports like schedules. We can use things like a first then board where it shows what you want the child to do first and then what they're going to get to do after. And the thing that's in the then spot should always be something that they really like, as a way to just kind of say, like, first we're going to do this thing that I want to do, and then we're going to do the thing that you want to do. It's really effective. We can also look at things like setting timers. Sometimes it's really difficult for kids to stay in a clinic room for a certain length of time, or if they're practicing like a physio or an OT or even an SLP therapy where they're doing treatment, and it's hard for them to be doing it for a long time. Sometimes we can just set timers and show them, okay, we're going to do this for 5 minutes and then you'll take a break. It goes a long way. This timer is really great. It's called the time timer. I don't know if anybody's familiar with it. But the wedge gets smaller so that the child can actually visually see the time that's going, because not all kids have an understanding of time. We can also use priming, so letting them know ahead of time using social stories or role playing. For older kids or teens, we can do things called behavior contracts. And this is just a fun way where you lay out, it should be a fun way, it shouldn't be where you're sitting down and laying down the law, but it should be a collaboration of what your expectation is, what they need to do, and then if they do the thing and if they meet the goal, what they're going to get as a result. Or what the deal is between you and them, or them and their parents, and then everybody signs off on it, and it's really powerful. A lot of teens really like it, because then they kind of have a document that they can hold and say, like, this is what we agreed, and it keeps parents on track too. And we can also look at some video modeling or things like that to kind of try to prevent those things. We also want to think about how many opportunities there are for the child to be in control. So we know that children, obviously, have less control than adults, as they should, but we also know that kids who have developmental disabilities or physical disabilities get even less control in their lives. So we want to build in as much control as we can, and sometimes it's really amazing when you just give kids more choice, how it reduces the behavior. Like it's crazy how just saying to a child, okay, well, we have to, if you have a couple of things that you want to get done with him, just saying, which one do you want to do first? You're still getting the things done. And sometimes just them feeling like they have a bit of that control does, it's actually insane. It's insane what it does. And they just do it. And the parents are like, oh. Not for everyone, remember, but for some. And the nice thing here is, too, we're promoting independence. And then especially with kids, we're kind of encouraging, we're starting to encourage self-advocacy skills, too, by giving them choice and being able to ask for what they need, which we know is so important as they become teens and then adults. So give them as much choice as you can. Be careful with the master negotiators that you don't negotiate too much. Or sometimes I come across kids who I'll kind of say, we're going to, you have to take a height and weight. Which one do you do first? And they say, no. And then I say, okay, it's your choice. You can choose height or weight first. And you choose or I'm going to. And they say no. So then I make the choice. And then if they say, no, I want this, too late. Because I'm a behavior analyst and I wouldn't have a job if I didn't do that. But you can use your judgment. Like if you kind of, use your judgment, if they say, okay, yeah, we'll do that, and then they're going to, and then follow through with it, but just be aware that you might get into a back and forth. It's okay if they don't take a choice that you make it for them. They won't do that again, right? The next choice you give, they'll take it. Okay, we also want to think about the actual task that you're asking them to do. So we can think about, do they understand what you're asking them to do? Can they even do the task? Of course, sometimes you're getting them to do things that they can't do. That's why they're coming here. So thinking about how you can break it down to make it easier, and to break it down, but then also to show them how you've broken it down. Because it's probably some things that a lot of you are doing naturally is breaking down tasks, but it can be kind of on a to-do list or on a schedule where it says, first take 3 steps, and then, climb the stairs, or you list all the things, the physical activities you want them to do, and they can rip them off or cross them out every time it's done. And it's just a kind of a bit of a satisfying feeling for a lot of kids to do that. It's kind of like if you make a to-do list, how many of you write make to-do list on the top? Right. Why do you do that?
Satisfaction of crossing it
Right.
off.
It's the same thing, right? So it's something that you're probably clinically doing, but just give them that little cross off. And sometimes that really, really helps, and interspersing easy and difficult tasks together. Also making the tasks more interesting or challenging if they're boring. Sometimes you can pair things that are very highly reinforcing, or people, with activities that they really don't like. So if they're having to do a chore or something they don't like, you can have their favorite music on, or you can try to make a game out of it or something like that. And we also want to give really effective instructions. So what I mean by effective instruction is us giving an instruction twice and then being quiet. So really, this is my recommendation to all of you to give instruction. Make sure the child is attending to you, or if they're, they don't have to be looking at you, because kids learn very easy if I turn away and then you won't tell me to do something. I'll just turn away a lot. And just make sure they can hear you or physically close to them. Use very clear and concise language. Tell them what you want them to do once. Wait about 3 seconds. If they don't start doing it, tell them what you want to do one more time. And then start helping them do it right away. So don't wait. Tell them again, and then start prompting them to do it. And whichever way you're going to do, if you're going to gesture to them, if you're going to physically help prompt them to do the thing that you wanted them to do. We want to avoid repeated instructions, because then they become very easy to ignore. And then also when kids escalate, we see that so many people are giving them more instructions, and it does not do anything to calm anybody down. If you think about the time when you're at your most stressed out, if people are just rapid fire things to you, you shut down even more. So really try to limit how much you talk. And in general, and I am the same, as therapists and clinicians, we talk a lot. We just need to really quiet until people invite you to talk, and then they all have to listen to you. Okay. The other thing to watch out for is to see if the child is only accessing the reinforcer when they're engaged in problem behavior. So are they getting soothing, calming? Are they offered choices of different things when they're engaged in problem behavior only? We want to make sure that we're doing those things when they're not engaged in problem behavior as much as we can, right? Because this way, if we're just kind of giving it to them for free throughout the day, then there's not really a need to engage in the behavior. It's classic because when, it's reasonable when kids are busy and they're like playing well independently or playing with a sibling or another peer, they're finally quiet, doing their home thing, then we as adults think, okay, this is my time. I can go write that note I need to do. I can go prepare this next thing. And then all of a sudden we see behavior happen. So we want to watch for those moments when they are doing exactly what we want to do, and we want to enrich their lives a ton. And then we'll talk about how we want to do the opposite when they're engaged in behavior. We want to show them that we're not going to enrich their lives as much when that happens. Okay? So just be mindful of it. It's not one of those things that we really think about until we collect data and we think, oh, now I can see what's happening. The last thing that I want to chat with you about is, are you catching the child being good? So it's really interesting that this in it of itself is one of the most powerful tools that I can tell you or parents to try. Sometimes just pretend like none of the problems are happening and just find things that they're doing well. And if there's nothing they're doing really well because they're having a really bad day, find something they're doing okay. And tell them. Be really specific about it. Tell them what's going well. Give them praise when that happens. Give them access to their favorite things when it's happening. Sometimes with kids who have a lot of challenges and engage in a lot of severe problem behavior, there's just so much focus on the negative behavior. And if we just flip it and give all the focus on the things that they're doing just okay, then that really changes it around, and it can really make a bad day an okay day, or sometimes even a really good day, because it's kind of just letting them, like showing them you're going to get what you need, it's okay. You don't have to do these other things. Okay, does anybody have any questions on some of those preventative strategies? I know it's like a whirlwind. Do you feel like there are some that you could use in your clinical settings? Yeah? Okay, great. Okay. So the second component is teaching replacement behavior, okay? So this is really just asking yourself, what do you want the child to do instead of the problem behavior? It doesn't matter what it is, whatever makes the most sense. You want to make sure that ideally the behavior should be easy for them to complete. It should be effective, meaning that every time they engage in it, if it's asking for a break, every time they ask for a break, you give them a break. And we want it to serve the same function as much as possible. So if they're engaging in behavior to access an item, we want to teach them to ask for the item. If they're engaging in behavior to get attention, we want to teach them to ask for attention appropriately, and whatever the easiest way, right? So if it's exchanging a picture card or just tapping somebody on the shoulder or anything, that's better than the behavior that they're currently doing. And with this, we can also think about sometimes when we don't really have a good replacement behavior because they have to do what we're asking them to do, we can look at how we can teach up tolerance or how we can teach kids to accept no as well, because sometimes things aren't available. So tolerance training, accepting no, can still be considered replacement behaviors. It's a skill that you're developing in the absence of the behavior. When we're teaching behaviors, we want to follow these general 4 steps. So first we want to figure out a way to set them up for success. So teach them to do the replacement behavior when they're already calm. It's not the time to teach them something when they are escalated. We want to think about how you can break it down. If we're teaching them to accept no, start with things that they already kind of can accept no to. Don't start with the biggest thing that's their most favorite that you're trying to take away. It will implode. Start with things that they're kind of okay with, and then you can gradually work your way up to the more difficult ones. If it's tolerating different procedures or activities where it can be time-based. You can get them used to increases in time or different procedures. It really depends on the procedure, but you want to think about how you might be able to break it down into steps so that you can get them to tolerate it. Then you want to help them actually be successful doing it, right? So prompt them through it. Don't just expect them to do it and then watch them try and struggle. Help them to do it, and then reinforce them for doing it or for even attempting to do it. Because remember, we have to reinforce if we want the behavior to occur again. So this is a non-optional step. You have to reinforce a behavior that you want to see again, otherwise you may not see it again. And then as they develop the skill, then you can gradually increase your expectation of them. Okay, so now they have to accept no for more difficult things, wait a longer period of time, or instead of, crying while asking for a break, now you're going to expect them to ask in a nice voice. Okay. The last thing, which I think is probably what most people come and hear behavior talks for, is, okay, great, prevent behavior, teach them a new behavior, yeah. What do I do when it happens? So when behaviors happen, don't be afraid of it. It's not a bad thing when behavior happens. This is your moment for the learning opportunity to occur. I know that behaviors can be really severe and scary, and definitely we want to make them stop, but in those moments, look at it as an opportunity, like, okay, this is where I'm going to do my teaching to try to change the behavior. So there's lots of different ways that we can change the consequences. But I'm going to share two of them with you because some of them really you must have supervision of somebody who has some expertise because it can go a little bit sideways. So the first one is extinction. So this just means whatever was previously reinforcing the behavior, whatever they were getting or getting out of for engaging in the behavior, they no longer get when they engage in the behavior. Okay? So that problem behavior no longer works. Ever. Okay, so ever. So if you're doing this, everybody has to be on the same page, and you have to be aware that behaviors will always get worse before they get better. So if you think about, if I go to a vending machine and I put, let's say, I put a loonie in for a Coke, which would be a really great deal, but I put a loonie in for a Coke, and I press the button and the Coke comes out, right? So I keep doing that in my life, and then one day I go and I put my loonie in, press the button, no Coke comes out. What am I going to do?
Hit the machine.
I'm going to hit the machine. I'm not going to walk away. I'm going to hit the machine. So then the Coke comes out. So then the next day I go and it doesn't come out right away, so I might be a little faster to hit the machine. Next thing you know, my new behavior is just loonie in, press the button, hit the machine right away. So look how this inanimate machine shapes my behavior. It totally changed my behavior, that now I'm doing this other thing. Okay, so then one day I put my loonie in, hit the button, hit the machine, no Coke. What am I going to do next? Hit it harder, yeah. So the only time I will stop hitting the machine and going back to that machine is if what happens?
Never get the Coke.
I never get the Coke, yeah. So this is an extinction burst, right? So behaviors get worse before they get better. If you can be consistent and follow through, this is the fastest way to change behavior. It's the fastest, it's the strongest, it has the strongest evidence for, it's the best. But the challenge is if you cannot safely ignore the behavior, then it's going to get worse. And then the problem is then that might be the new behavior, right? So there's obviously some behaviors we can't do this for if they're unsafe or dangerous. Sometimes we do extinction for behaviors that are unsafe because we don't really have anything else to do, but only attempt that if you have a behavior analyst who's helping you with it, who can kind of understand and put in some other safeguards and make sure that you have a really good preventative strategy and replacement behaviors. But especially for toddlers or behaviors that aren't dangerous, there's no aggression or self-injury, give it a whirl. Just be ready. And I will just say, it depends on the behavior, and how often the behavior happens. It shouldn't take more than 2 weeks, and sometimes it takes one day or one time, and then it's over. But you have to be ready to ride it out for about 2 weeks. Okay. So when extinction is not safe or not feasible, what do? So here's what you do. You wait. Wait for just the briefest calm time. right? So when a child is escalated, if they're physically aggressive, just stand back and wait a minute. As soon as they're calm, just for a second, then you want to help them engage in the behavior, the replacement behavior, right? So then you want to tell them, ask for a break, or to say, I need a minute, or something, and then honor it. So technically you are reinforcing the behavior, but what you want to do is when you honor the break, it should be very neutral. You give them the break, but the break should not be as fun as if they asked for it without the behavior. So you're kind of teaching them that if you don't engage in the behavior and you use the replacement behavior, your life gets better, we get to have lots of fun together. If you engage in the behavior first, and then I have to help you to use it, then I'm going to honor it, but I'm going to give you a lower quality of reinforcement or less time. So maybe the break is only 2 minutes instead of 10. Maybe there's no toys during break, or just some toys that they kind of like, but there's a ton of toys if they ask for it. Do you understand the difference? So this is also effective. It will take longer though, because it takes some time to kind of learn the differences between those two things, but it can be very effective. Okay, so these extinction and this kind of waiting out will really be more useful for you for those kids that you see on an ongoing basis, right? Kids that you see, they come into the clinic once and then you don't see again, or you don't see for months later. It's going to be harder to do that because you're not going to change behavior in a one-time day, right? So there's a couple of tips that I have for you that what do you do in the moment that a behavior happens, right? So ask yourself these questions. Is there an immediate safety risk? If the answer is yes, then you will call for help, right? So you'll use whatever Bloorview systems are for dealing with a crisis or an unsafe behavior and do what you need to do to de-escalate, right? It's okay if you reinforce. I don't want you to think like, oh, I can't reinforce. The kid's going to hurt themselves or somebody else. That's okay, reinforce. You can look at it later, right? If there's not an immediate safety risk, can you prompt the child to engage in the replacement behavior, which we just talked about, right? So if you can prompt them to engage in it, do when there's a calm moment. You can also think, though, if you can safely ignore the behavior, then do it. Okay? It's using extinction. You might not see long-term results, but ignore the behavior, not the child, the behavior. I call it tactical ignoring. So you're very aware of the child, you're watching them, you're making sure they're safe, but you're not attending to the screaming or the hitting, or if they're hitting you, not if another child, or any of those things. So you kind of like stare at a ceiling, just very neutral, and just wait for them to stop. Quietly. Wait for them to stop. Once they stop, you can go about your day, right? So then you go right back into, can I prevent things? Can I build in choices? Can I show them things? Any of those things, okay? I wish I had like a quick fix. It's like, if you say this, they'll stop. I don't. It's hard, right? If any of you have changed behaviors, if any of you have tried to exercise more, eat better, quit smoking, any of those things, it's hard. Behavior change is hard, right? So there's no quick fix, but this should help. Just kind of cool, calm, and collected, wait for it to stop and move on. Okay. So I just want to show you, because we've talked so much about kind of in theory, what can you do? So I thought I'd just share a case with you and then I'll answer any questions. So you could kind of see how we use those three components to actually deal with a challenging behavior that may be something that you might encounter. So there was a young man, Andy, who I treated. He was 8, he had autism and ADHD, and he was having some adverse side effects to the ADHD medication that he was on. And a psychiatrist wanted to prescribe an alternative medication, but it only came in a pill form, and every time Andy was given pills, he would spit them out. And so they couldn't prescribe. It really limited what they could prescribe. So I went to the home and I observed, but I also just spoke to parents and said, okay, kind of what's happening. So the function of spitting out the pills was escape. So I'm sure he didn't like the taste of it or the sensation, but the act of spitting it out was to get that feeling, to get out of that feeling, right? So then we can kind of look at his behavior plan. So first, for the preventative strategies, I explained the expectation to him that we were going to swallow. I give him a choice of a chaser, what he could swallow the pill with, based on his favorite drinks, which were Coke and milk. He chose Coke. And then I gave him a visual schedule that said, first we're going to swallow, and then you get a star. And we set up a program where after he got 5 stars, he got to have the iPad for a little bit of time. Okay. So then in looking at the skill promotion, we wanted to break down the steps to make it easy for him. So we started with really small items, so those little silver ball sprinkles, you know those ones? So we had him swallow those first. We obviously didn't want to use real medication because we didn't know if he would get the dose, and we wanted to practice it a whole bunch of times, right? So we did that and modeled how to swallow. So we showed him, he got the Coke as a chaser to do it, and then as he was successful, and then we moved on to bigger items, so Tic Tacs. And then once we could see that he was consistently swallowing a Tic Tac, which is actually pretty big, then we could move on to actually the medication. And the way that we modified our reinforcement is that if he spit out the item, if he went to spit it out, we put it on a plate, and then he was immediately presented with another item to swallow right away. And then after 5 stars, he got praise and the iPad. So this is kind of an example of how you can use the prevention, a skill replacement, and then looking at the consequences. And if you've ever worked with a behavior analyst, we really like graphs, and I won't go over all of this in detail, but all you need to notice is on the first day he wouldn't swallow anything, and then we were able to teach him to swallow pills until he could swallow 100% of the time. And then eventually the bars or parents just started giving him a vitamin to swallow, which was pretty low risk. And then he just started swallowing. So then his medication could be changed, and he can be prescribed whatever a physician wants to, and he'll take it now. So it works. Okay, so the last thing is just how do you know if you've been effective? This is something that I think is a really nice strength of applied behavior analysis that can be applied to kind of all fields. And this is just to take some baseline data. Just look at what's happening with the behavior, how often it's happening, what's the severity of a of a wound, how many steps can they take, how many letters can they print, implement those strategies, and then just ask yourself, is the behavior happening less often? Is it shorter duration? Is it less severe? Is the replacement behavior happening more often? If you're answering yes to those questions, then you have a successful plan. Keep using it. You can start to fade out reinforcement and increase your expectation. And if the answer is no, don't change everything, but just look back at your plan and try changing one component. Usually, it's that the reinforcement isn't actually reinforcing. So the thing that we think that they might really like, but for whatever reason is not as valuable to them to change their behavior. Or the other thing is sometimes we see a lot of inconsistencies with the clinical team or the parents, right? And it's okay if parents aren't 100% consistent. Kids will learn with mom I do this, with dad I do this, or grandmas I do this. It just takes a lot more time. So ideally we want everybody to be consistent. Those are usually the 2 biggest problems because you've done all this work and put all this thought in, right? So just look at those things and then try it again and keep collecting data and just evaluating. Okay. So now we have time for questions. Whew, sorry, that was a whirlwind 4-hour workshop in 50 minutes. Okay, who has questions for me? Yeah.
How do you do tolerance training?
Tolerance training?
Yeah.
It depends on the skill we're looking at.
Like, say, tolerance to waiting.
Tolerance to waiting? So we figure out what they love, and then we literally do, we usually use like a visual or something. I like to just teach kids the visual of this hand because that's what people are used to, like wait. So it'll literally be wait, and then give them the thing right away. So they're not even waiting a second, and then slowly increasing the time. So it might be, okay, like this is, okay, it's my turn, wait, here we go, give it back. So and then through subsequent trials, so it might take like 50 trials in the first day, but they're fast. So we do things like that, and then we bring them into other environments. So if it's like waiting at the grocery store or waiting for your turn in the ball pit or something like that, then we slowly fade it to that.
We do a whole program.
Yeah, we do a whole program. Yeah, but it doesn't have to be. It can just be like really quick. Like it's kind of common sense as it's kind of like getting better. Sometimes for kids that really struggle, we'll use other visuals, like it might be I've done where it's like a puzzle. So like every time they wait like 30 seconds, I put a piece of the puzzle on, and then when the puzzle's complete, they know the time's done. Or the reverse, where we take things away, depending on what you think the kid would like, just so they have like another visual for them, or the timer. Because the concept of time is really hard for kids, right? Sometimes it's hard for me. I like 5 minutes, I was waiting for a phone call, it was 5 minutes, felt like an hour, right? Yeah.
You talked about teaching kids to ask for a break as a unhealthy behavior, a different behavior.
Yeah.
What if they then start to ask for a break, get a break, then you're back to it, and they ask for a break again?
Yes. Yes. So well done. You taught the behavior. So now, so that's good, right? So if that's happened, they've learned the contingency. I ask for this, I get the break. Then you're looking at tolerance training. So then what we start to do is we start to slowly fade in every once in a while saying, not yet. Or, sure, you can have a break in 2 minutes. Or first this and then a break. So if it's 100%, 100% of the time they ask for a break, they get a break. And then we might change it to 90% they get a break and 10% they don't. And we intersperse it depending on the child, and then we fade it to the point where we can just say, sorry, not yet. But it's gradual, and you want to have something. The key is what's in it for them. What's in it for them to do this thing they don't want to do? So you want to have that thing and say, like, no break right now, we're doing this, but then you can have this during your break, so that they have a little bit of incentive and motivation for it. Yes?
I work with volunteer resources, and I think this probably comes up with parents sometimes too. I've heard from some staff that volunteers are sometimes reluctant to follow through on these types of things because they feel like they're being cruel to the child.
I know.
So what can you say in that situation to help them understand the importance?
Yeah, it is hard. I'll just repeat it. When people think that like following through behavior plans can sometimes be cruel, it's hard because the way we talk about behavior too is really cold, right? Like my profession has a bit of a PR problem because we talk about things like antecedents and consequences and automatic reinforcement, right? So I think the thing is educating the volunteers and letting them know why you're doing it for this specific child, and then I think if they have an understanding of what it means for that child and why the plan's been there. The other thing I find really helpful when people are reluctant is try to talk about it in terms that they themselves would see. So if it's something like, if every time, I'm trying to think of a real life example. If every time I came in and was grouchy to a colleague, they bought me a coffee, I might start being more grouchy. So that person might say, I'm not buying you a coffee today. And in fact, maybe I just say hi and then get back to work. Like maybe it's like a little shorter of a hi, right? So sometimes when you like refer to it in ways that like we understand our own behavior, then it feels less cruel. It's like we're teaching the same skill to the child. But I think the education is the biggest piece, and letting them know not following through is actually way more harmful because of where they can be. And for anybody who's worked with teens or adults who have challenging behavior, it's so much harder to deal with it. The larger they are physically, the more difficult it is, right? The scarier the behaviors become. So yeah, that. Anyone else? Yes.
We're therapeutic clowns, and we've noticed that for really adverse behaviors, when another clinician is bringing us in to kind of see what can be done.
Mm-hmm.
And I don't know, I'm just curious if there's a name for this, because we just do it on instinct. But we might, if it's a bath that they don't want.
Yeah.
We're outside the bath and the bathroom door, and we put the focus on us and our problems, or we might say, I can't wait to take a bath with my boots on.
Right. Yeah.
The kid is kind of like,
Yeah.
no, you can't. Like she's just forgotten about her problems for the
Yeah.
Now she's like concentrating on these idiots who don't know how to do that.
Yeah. You're pairing yourself.
Is there a name for it?
I think I would conceptualize it that you're pairing a non-preferred stimulus, the bath, with a preferred stimulus, you, right? And suddenly the bath feels like less of a big deal, right? If they're in the bath, but something else fun and exciting is happening, and you're transferring some of your like reinforcing properties of you being there to the bath, and the bath becomes easier.
Like we also don't want to. We want to be careful that we're not being treated as a present, as a reward.
Yes.
Which is a really, really hard thing for us, because we don't want that. Like we're going to see them anyway.
Yeah.
Whether they behave well or not, right? So,
Right. The thing that I would like I would say about that is like, yes, like, you know, you want to see those kids, you want to brighten their day. The only thing I would caution on is if a child is in in a problem behavior, severe problem behavior, if you come in right after, you will likely see that behavior get worse. So just letting the behavior de-escalate, that would be my only suggestion, making sure that you're not coming in as a way of, oh, you're just hitting everybody, let's bring in the clowns and then you'll stop hitting. They're going to get hit even more, right? So just waiting for that delay or seeing, you know, if there's a certain time or certain things that are happening that make it more likely for the child to start hitting, maybe during those times you come in beforehand, before they start the process. Yeah. Yes.
What you just said.
Yes.
Nurses are really savvy about not having us come in after.
Yes. I'm sure. Yeah.
Yeah, I was just curious if there's.
Yeah, I would say, if you want to be real technical, you can say I'm pairing a non-preferred stimulus with a preferred stimulus. If you want to sound a little bit more warm, you can say I'm pairing something they don't like with something they really like. Well, okay, great. Email me if you have any questions or if you want the PowerPoint. I'm happy to do that.
All right. Thank you so much, Justine.